Good morning. I'm Massimo Antonelli, head of the Department of Intensive Care and Anesthesiology at the Cattolica University in Rome, Italy. My task today is to speak about the possibility of tracheotomized the COVID-19 patient for delivering respiratory support. This might have conflict of interests. If we look at the indications of tracheostomy, we have to stress that they are in large part adopted for facilitate prolonged mechanical ventilation, or in case of obstruction for sleep apnea or tumor to bypass the trachea, and also to maintain the open, patent the airway in patients who had severe head and neck injury, for airway abnormalities, secretion removals, and recurrent aspiration. In this case, the first point and the secretion removal remains the main topic that pertains this presentation. Recently, we have published, working in an international panel, including colleagues coming from all the continents, a sort of guidelines, a multidisciplinary guideline, where we analyze the various moments, advantages, and problems concerning the the tracheostomy in COVID-19 patients. If you look at this graph that depicts the various moments of the disease, including the incubation and the full infectivity and infections, and you move looking at the permanence on the period that they spent on the ICU, are on ICU ventilation in periods that shows also the persistence of infectivity, you may immediately realize that at least for those patients who remain on prolonged ventilation, the tracheostomy may be indicated. But in general, having a survey done preliminary just to investigate how is the diffusion of the tracheostomy practice in the various countries, this regards no more than 5% of the ICU ventilated patients. Just making this survey, you can show how, in comparison, in the various moments of tracheostomy application, earliest, most common, and latest, always a difference in respect to those patients who are non-COVID. Those who are COVID patients, in general, are tracheotomized regardless the time after a period longer in comparison to patients who are no COVID patients. It is important to remind that the tracheostomy window regards all these problems and however represents also some important limitations that should be taken care in consideration, like the ability to communicate. But all these different conditions are in favor of early tracheostomy, but considering also the potential risk for the healthcare workers and families, these are in favor of delayed tracheostomy. Also, for these reasons, considering the need of the tracheostomy for these patients in a period when they are still infective. It is important, however, because there are various critical moments during the performance of the tracheostomy, that we need to minimize the disconnection for the ventilator circuit, reducing the aerosolization to the staff. And especially should be avoided any form of non-fenestrated tube, using inline suction, and avoiding any form of airway intervention. One of the practical recommendations should be that of keeping the cuffs of the endotracheal tube while performing the tracheostomy at something in between 20 and 30 centimeters of water. And this should be also maintained after having performed the tracheostomy. As soon as we have the need of change the tubes, this should be delayed until the patients should consider non-infection. Recommendation is always to use an HEPA filter or heat and moisture exchangers in order of provide an adequate humidification and avoid generation of aerosols. Practical recommendations regards also, while performing the tracheostomy, the reduction of positive end respiratory pressure at 2-3 centimeters of water, high FiO2, use of HEPA filter, and complete protection with appropriate devices for patients. These guidelines summarizes also the various recommendations with some comments, and including also the optimal management of the tracheostomy. And also it stressed not only how to perform the tracheostomy and where there are the major critical moments, but also how should be recommendable taking care of tracheotomized patients. There is also another guideline coming from the American College of Chest Physicians. And in this program, the general risk reduction practices are enlisted with the specific reference to the use of ultrasounds to assess the anatomy, the use of this sedation, and the use also of moment of apnea in order to reduce the dissemination of droplets into the environment, increasing also the FiO2, as I mentioned. And it is described the various K intervals when must be performed a moment of apnea, such as, for instance, the introduction of the cannula after the dilation percutaneous tracheostomy, avoiding always any form of diffusion. However, the frequency of tracheostomy may vary a lot depending upon the various sites. In this study that was performed in the New York University, the patients in a sample of 270 patients, 30% of them received tracheostomy. These are obviously all COVID-19 patients. But if you look at what happened in Italy, for instance, during the most serious moment of the pandemic, no more than 10 or 12% of patients who stay in the ICU for prolonged mechanical ventilation received tracheostomies. Most of them, even though later, were weaned from the mechanical ventilation. Which are the conclusions then? The length of mechanical ventilation in the ICU often exceeded 10 days. But don't forget that the late weaning may be possible, and for these reasons, maybe it's also possible to avoid the tracheostomy, if not necessary. The tracheostomy is a procedure that needs specific precaution and adequate individual protective measures and devices. And once again, it's important to select the patients, taking into account the risk factors and evaluate it carefully to minimize the problems for the healthcare workers. Thank you.